Okay, welcome everyone on board. Today we will just quickly review some important points and major points about obstetric gyne obs anesthesia. Uh, okay, before we just start, can someone just quickly review the changes, the effects, and how to manage in these three aspects the changes in the pregnancy. Abdurrahman, would you like to tell? Uh, can you hear me? Who would like to answer? Wajiha?
Yes, sir.
Yes, actually, just concentrate on this format. That what are the changes, what are its effects, and how to manage with reference to pregnancy.
Yes, sir. So, physiological changes are may lead to cardiac and respiratory physiology,
No,
and
again,
on
again, I'm sorry, I'm stopping you. Think about that. I'm giving you one example, and then you convert. Like there is a decrease in FRC, okay, because of gravid uterus. So you pre-oxygenate and you do ramp. So this is the change, and this is the effect is easy desaturation. Okay. So you do ramp position and you do pre-oxygenation. Now, whatever you were saying, convert it into these three steps. That what are the changes, what are its effects, and how to manage.
so, so in a pregnancy, blood pressure decreases to 20%, and SVR also decreases. And to compensate this, blood volume and cardiac output increases, and stroke due to stroke volume.
No, no, you are not understanding.
Sir,
Okay,
SVR
if you want to say tell the same thing that SVR is decreased, so there is decrease in blood pressure, okay, and there is increase in volume. So we give like restricted fluid. But actually, the main things with reference to airway, how will you explain?
सर वो सॉरी मेरे कनेक्शन में वो डिस्टरबेंस होती है मुझे पूरी
Yes.
आवाज नहीं आपकी आ रही थी
Okay, I will repeat. Actually, first of all, there are some international people here today. So try to speak in English. So I told that, like in airway, what are the changes and what are its effects on anesthesia and how you manage them.
सर सॉरी माय कनेक्शन इज अनस्टेबल आई कांट हियर यू प्रॉपर्ली
Just a second.
सॉरी मे बी आई चेंज माय पोजीशन वेयर
No, no, I
आई एम
think
सिटिंग
its problem is with me. I think problem in my connection. Just a second. Am I audible to you now?
yes sir sir you were asking about the fluid management
No, no, I'm asking about changes. with its effect, and how will you manage? Like, for example, I give you one example that there is decrease in FRC because of gravid uterus. So there is easy desaturation. So you need to have pre-oxygenation and you have to make slightly ramp position. Okay. So now you
Yes,
just think about what are the changes in airway and what are its effects and how you
yes, sir.
manage.
So there is a decrease in SVR and blood
No,
pressure
no, airway,
physiologically in
airway, airway,
pregnancy,
airway,
and so
airway.
we have to
हाँ
give uh,
नहीं
fluid,
सर
and
दोबारा
also वो aorto cable compression. We will
Mm, I'm afraid you are not understanding my question, Wajiha. With reference to airway, how can you explain?
so airway there is uh, due to low gastric what should I say that
Like, what about the airway, the engorgement?
okay, so due to delayed gastric emptying and lower esophageal tone uh, is decreased, so there will be more risk of aspiration, and
Okay, no.
these
What
pregnant
about
ladies will
engorgement of
be.
airway? What about engorgement of airway?
Sir, sir,
So you leave.
if a patient is like is if there is preeclampsia or hypertensive patient, then there can be edema of airway.
No, no, no. In pregnancy overall, there is engorgement of airway. So usually we use slightly lower size of endotracheal tube.
Okay,
Okay.
sir.
And in the laryngoscopy, the laryngoscopy, and so because of breast tissue, there is difficulty in doing the laryngoscopy. Okay. So that's why
Yes,
the purpose of ramp position is also this one. Okay, then what else change? As you were saying, that there are increased gastric
uh,
volume because of gastroparesis. Okay, because of why gastroparesis occur? Abdurrahman, I will come to you. How gastroparesis occur? Because of what's the reason of gas?
increased pressure
No, progesterone.
or due to progesterone. Okay, hormonal
Progesterone.
effect.
Not only there is gastroparesis and there is decrease LES tone, lower esophageal sphincter tone. Okay. So all these factors predispose
Little
to
consumption of this please.
aspiration. Okay. I'm sorry. Okay. So all these factors predispose to aspiration. So what you do, Vajia, for these things, we do rapid sequence reduction
So
or
rapid
modify.
sequence reaction and antacid prophylaxis and
Very good.
RSI.
Required pressure. Okay. Acid
Yes, sir.
prophylaxis.
Yes, sir.
Okay.
And if there is engorgement of airway, we use a tube lesser number
Yes.
less than
And we use
the
careful laryngoscopy. Okay.
careful endoscopy. Yes, sir.
And we do RAM position. So RAM
Do
position
ramp
means
position.
rapid airway management position, in which we position in a way that the external auditory meatus, okay, external auditory meatus becomes at the level of sternomental angle or
Management.
angle of Louis.
Yes. Okay.
Okay. Okay. So what about effects on the central nervous system? Abdurrahman, now you were raising hand, so you can tell.
Yes, sir. So, one thing is there is decreased MAC and decreased requirement of local anesthetics for regional and local infiltration due to progesterone.
and
Also,
and
uh,
increase epidural.
and the decreased doses of uh, local anesthetic in uraxial block due to increased venous plexus congestion and decrease intervertebral space and decrease CSF in uh, central nervous system.
Yes, so that's why you decrease the dosage of the medications,
So
okay?
yes,
And you do decrease the dose of local anesthetic.
volatile.
Okay. So what about this one? What's the reference of coagulation?
So with reference to coagulation, there is uh, increased level of antithrombin 3 and decreased level of factor 1, 5, 7, 9, 10, 11, and I
Increase,
think 12.
increase factor.
Increase, yes, increased level. So it's a hypercoagulable state.
State. So you
We we do DVD prophylaxis after first trimester.
so DVT prophylaxis. Okay. And also we don't try to don't not to have dehydration.
Yes.
And so this is another point. Okay, what about respiration, like oxygen consumption and all this?
Sir, tidal volume is increased by 50% while respiratory rate is slightly increased, leading to increase in ventilation and uh, a slight respiratory alkalosis. Oxygen consumption is increased,
Just
but
a second.
also the possible.
Abdurrahman, now I just want you to understand that in your fellowship exam, nobody will ask you these changes separately. Okay? So you just have to
Yes,
say that this is the changes. So you have to monitor them intraoperatively. So intraoperatively, you have to slightly hyperventilate. Okay?
sir.
To maintain the changes which are there because there is more oxygen consumption. So actually the minute ventilation need to be increased, and especially when you are doing the positive pressure ventilation, these effects will be more even because of gravid uterus and everything. Okay.
Yes,
So
sir.
you just have to translate the changes into the business end, like the practicality what you will be doing. So you will be doing rapid sequence reduction, you will be doing acid prophylaxis, you will be doing cricoid pressure, you will be reducing the dose of MAC, and sorry, reducing the medication doses. Okay. What about muscle relaxants? What about muscle relaxant, Abdurrahman?
Sir, वो
Uh,
due to decrease osmolality and decrease albumin globulin ratio and volume distribution increases, so increase doses of drugs are needed.
No, but try to be again practically divide it. Like, what about depolarizers? The duration may be increased or decreased.
Sir, वो cholinesterase activity decreases.
So due to pseudocholinesterase activity decrease, so they may be increased duration. But the dose, is it affected? Initial dose,
no, sir.
There is dose effect remains the same.
yes. Okay. So just a second. Okay. Anything else? Zishan, you have just joined. We are just trying to discuss the changes in pregnancy with reference to their effects and um, like clinical management of anesthesia. Okay. So we have to do acid prophylaxis, we have to do rapid sequence reduction, we have to like use slightly smaller size of endotracheal tube. Okay. What else? We have to give DVT prophylaxis. Anything else comes to your mind? Are you here, Zishan? Yes, Zishan, can you hear me?
Yes, sir. These
अभी पूछा हुआ है
are the
Sir, वो renal effect GFR increases and creatinine levels decrease. Creatinine clearance increases.
No, but practically, is it important?
No, sir.
Like not like no, sir, but everything is important, but try to make, because they will not, the question will least likely in the fellowship exam that they were asking you what are the changes, physiological, pharmacological, and anatomical changes in pregnancy. They will be like, because they will be asking you a scenario in which you have to explain to them somehow that what will be the change in the pregnancy which is changing your management. Okay, so like for
Sir,
example, yes, like with
sir,
reference to
in,
C. Mhm.
on musculoskeletal system, due to laxity of ligaments and spinal lordosis,
Yes,
regional anesthesia can become difficult, and there is epidural space decreases.
shrinkage, chances of PDPH. Okay, like this. I hope you understand. Okay, so musculoskeletal we covered, neurological we discussed about MAC. So I'm just passing through them that if I miss anything. Okay, CSF pressure is increased even during contraction. It can reach up to 70 millimeter of mercury. Okay. Then some points about aortic cable compression, like you were telling about this renal. So GFR is increased. So creatinine, clearance of urea, uric acid, and creatinine all increase, and their plasma concentration are lower in pregnancy. But practically, how much is it effect? I don't think so. It's too much significant for anesthetist in the conduct of anesthesia. Okay. Hematology we discuss, RBC volume also increase. Okay. And plasma volume increase more than red cell volume. So there is physiological anemia. Okay. So viscosity is decreased, and actually this is also required with reference to rightward shift of oxyhemoglobin dissociation curve, which is required. Okay, so now a distracting question, which usually they will not ask, what is double Bohr effect? What is double
sir,
Bohr
double
effect?
Bohr effect is a sir. It is a phenomena in which, in the normal physiological state, there is a rightward shift in the maternal. There is a rightward shift for oxygen dissociated curve, but in the placenta, in the for the baby, there is a leftward shift of the oxygen dissociation curve. So the blood can be more transferable to the baby. So there is one in the baby there is leftward shift, and in the mother there is a rightward shift, sir.
Not
So
blood,
that is
the
known as double
things.
Bohr.
Yes, the things like which are transferring. So it can result in trapping of some medications. Okay, so one of the example is local anesthetic, if I'm not wrong. So this is how you can explain to them. Albumin level drops, so free drugs can increase. Okay, um, plasma cholinesterase enzyme decrease by 25. So succinylcholine effect can be slightly prolonged. Coagulation, hypercoagulable state, thromboembolic phenomena can occur. Yes, with reference to CVS, like because there is hyper circulation, like there is high cardiac output. So there may be some flow murmurs. So, and actually, if highest cardiac output just after delivery, so they can affect the like patient, if there is any cardiac decompensation can occur because of overload. So this is one thing which you need to understand. And with reference to blood pressure, diastolic blood pressure falls more than systolic because of SVR. So this is few points you should be knowing. There may be some murmurs. So I think, and now to summarize, as I told you about this one, difficult intubation and need of ranges of endotracheal tube and smaller size tubes, FRC decrease, and lowered levels of arterial PCO2, during mechanical ventilation. So you have to maintain them. Reduce compliance necessitating high airway pressures. And another thing, because I think the muscle in certain obstetric conditions, if the patient is taking any medications like magnesium, so the effect of muscle relaxant can be increased. So you have to consider these things. If you are giving saxamethonium effect may be increased. So these are some things. I think T3 thyroid gland hypertrophy during pregnancy, increased production of thyroxine, and are normally balanced by increased production of thyroid binding globulin. So the levels of free hormone remains the same. Levels of parathyroid, these are some extra things. Uh, so you just have to translate these changes in the practical conduct. Okay. So now, similarly, they can ask you a scenario that a pregnant patient is coming for lap appendicectomy. So you have to tell the same things in this way. So now, if you understand this thing, the same answers you will be uh, telling in the non-depolarizing muscle blockers remain the same. I think increased. Just confirm it. The effect of non-depolarizing muscle relaxant is increased or decreased? What? I think it should be increased. Am I right? Just correct me, please. Yes, Wajiha or Zishan? Just a second. Can you hear me? Is there any problem in internet?
Yes, sir. We can hear you.
Okay, so can you just correct me that the muscle relaxant, the non-depolarizing muscle relaxant effect will be prolonged or the same?
Sir, no idea.
Just
So I think
someone
it
just
remains same. So I think it
remains.
remains same, sir.
Okay. Okay, so I had a little bit of doubt, so I'm not saying anything. Anyway, so now rest of the topics. So you see, there will be certain conditions which can occur in pregnancy. Okay, like any diseases, decompensation, like myasthenia gravis, like multiple sclerosis, sickle cell disease. So actually, you don't need to be worried because the same considerations in a pregnant patient and same consideration of sickle cell disease, you just have to combine them, but their effect will be slightly more. Okay, like there, if the practically the effect will be more than isolated. So you just have to consider this thing in your mind. This is one point. Then they can ask you a question about obesity in pregnancy. So all you can make a list of these things: obesity in pregnancy, DKA in pregnancy. These are all questions which they have asked in differently. Cardiac disease in pregnancy. Okay. And then they can ask, and even you will find here neurosurgery in pregnancy. Okay, there is an article about I saw here somewhere. There is neurosurgery in pregnancy. So the thing is that you don't have to be worried, okay, because the concerns will almost be the same. You just have to combine the both the things. Okay. So let's discuss few of the scenarios one by one. The one I have asked, if you can just quickly, anyone wants to tell what will be the considerations of a pregnant patient for uh, appendicectomy. What things you should be remembering? Any other exam candidate who wants to speak out? Abdurrahman, if any other, if I
Yes, sir.
nobody's, yes.
Sir, anesthesia consideration would include the physiological, pharmacological, and anatomical changes in a
Okay.
pregnant patient,
Mm-hmm.
and including the uh, related to surgery, whether it's open or laparoscopic, and depending upon the appendicitis, whether it is ruptured or inflamed, and it would include whether uh, uh, think
Like you just be thinking that whether it is a pregnancy related thing, maybe misdiagnosis. Okay. And if it is mass or it is so if you are doing laparoscopically, just remember not to forget to tell that they have to keep slightly lower intra-abdominal pressures. Okay. And more important thing will be, like you directly jumped into the intraoperative, you just have to make sure you take the consent that usually the surgery should be done better time is second trimester. Okay. If of course appendix is a relatively urgent procedure, so they cannot delay. But any surgery which cannot be delayed through the course of the pregnancy, if it is in first trimester, try to push in second. If it is second, it's better. If it is third, try to do it after the course of pregnancy. In first trimester, there is chances of abortion, and in second or third trimester, there may be chances of preterm labor. Okay, so you just have to take the consent or monitoring for the fetal, fetal CTG throughout the procedure. They have to do an assessment before the procedure, remain monitoring throughout the procedure, and post-operative, and they can use some tocolytics. Okay. So can you tell me some of the options of tocolysis? What are certain options of tocolysis?
uh, yes, sir. Sir, tocolytics we can use indomethacin, uh, nifedipine,
Indomethacin. Indomethacin is
magnesium.
tocolytic. So tell
Ritrodin.
Sir,
sorry,
I think
ritodrine
so.
or salbutamol, and then
Yes,
nitrates. Okay.
yes, sir.
And our inhalational agents.
Terbutaline. Yes,
Okay. So
yes,
like
yes.
indomethacin, how will you use intraoperatively?
Sir, मैंने अभी पढ़ा था. I just read it that it's a
Yes.
tocolytic.
So
So
just try not to vomit out everything you read. Okay.
okay.
I know that there is nausea whenever we read something, there is severe nausea and we want to vomit it out. So, but try to control. Okay.
Yes.
So magnesium sulfate also is sort of tocolytic. So, and the same actually tocolytics, they can ask you with reference to, they can give you a scenario that there is uterine inversion, okay, following delivery, and they want to relax the uterus. So in that case, you can tell these things. Similarly, so you just have to understand what you need to tell. So tocolytics, CTG, monitoring, consent, okay, because there may be uh, abortion or preterm labor. Okay, so these are the things. Other than that, the rest of the thing we have discussed. We will be doing rapid sequence reduction and all the care which we have discussed. So if we understand, you just have to tell in every case, you have to tell the same things, same problems in any other scenario. Okay, so next scenario we will be practicing is bleeding. Okay, so what different sort of bleeding can occur in a matter like pregnancy?
Sir, it could be antepartum hemorrhage or postpartum hemorrhage.
Antepartum hemorrhage or postpartum hemorrhage, and one other category you can do painless or painful.
Yes.
So painful will be with
Painful, sir, would be placed central abruption.
abruption or uterine
Uterine.
rupture.
Yes, sir. Before you try and rupture, it would be painful. After, it would be painless.
So placenta previa is painful or painless?
Sir, painless.
Okay, so it is painless. So what else? Oh, for example, if you just chalk out these uterine rupture and abruption and placenta previa, what else should you tell? Differential diagnosis of bleeding overall.
It could be a coagulopathy patient, could be a
Very good.
non-disease of
Coagulopathy or coagulation defects.
yes.
What else?
Hematoma, epidural hematoma.
Epidural hematoma will cause maternal bleeding. No, you're right, wrong. Okay. Epidural hematoma, how it will. Anyways, infections. Anything
Yes,
else?
sir.
DIC,
DIC, yes, very good. Anything else?
So can be ruptured
It could be the trauma. It could be trauma.
It could be a trauma.
And
Okay. So
Ectopic, it could be ectopic.
yes, so you can see in the screen. So it may be sepsis, like as I told you, infection. There may be retained products of conception. Okay, and um, these are the things you should be just thinking in your mind. So you can divide them. And another thing is, if you don't overdo the classifications, okay, try to be as quick as possible and try to prioritize important, because sometimes when you classify, sometimes you are telling the thing in the causes which are not very important. Okay, so try to make your plan in a way that you don't overdo anything. Okay, so you should be thinking that whenever maternal bleeding comes in your mind, so placenta previa or abruption or rupture or the common coagulation problems, say the common things first. So this is the more important thing. Okay. Uh, so DIC, how occurs if it is amniotic fluid embolism, intrauterine death, sepsis, preeclampsia, abruption, retained product of conception. So, okay, so how will you manage? If you have a patient who has like a peripartum hemorrhage, peripartum, I'm telling you the both in whether it is antepartum or postpartum. So if it is peripartum hemorrhage or bleeding, what are the general principle? How will you answer the question?
so my
Same.
general approach would start from ABC.
Yes, ABC.
Uh,
In ABC,
uh,
how can you tell?
Maintaining the airway, maintaining the
Oxygen,
oxygen, and um, getting two large 14 gauge IV lines, checking blood pressure, heart rate, signs of shock. If patient is getting a brief history, if I can, and activating the massive
massive
transfusion
transfusion
protocol.
protocol. This is the most
Protocol
important thing. Okay, very good. Very good, Abdurrahman. MTP, what else?
activating the massive transmission protocol and involving a multidisciplinary team of obstetrician, second anesthetist if available, pediatrician, vascular surgeon, interventional radiologist,
Blood bank,
informing, yes, hematology and blood bank,
hematologist, hematologist.
yes,
Okay.
and blood bank.
And now another some
Inception,
more thing, there will be some surgical maneuvers to do it. Okay. There will be some pharmacological maneuvers, radiological. Okay. And in surgical, what will be the surgical options?
the surgical options would include V-line sutures uh, and internal iliac ligation, hysterectomy, and
Internal iliac ligation, hysterectomy. Actually one thing which I think in Pakistan, because it's not freely available, there is a Bakri balloon. Okay, Bakri
yes, sir.
balloon for
And
balloon tamponade. They just put it in vaginally and they inflate it to just tamponade the bleeding. Okay. So these are the things, the pharmacological, what options you can use?
Utrotonics we can use,
Very good.
which include oxytocin, ergometrine, and
Yes.
carbaprost, misoprostol.
Sir,
Okay.
there are first line and second line drugs. Tonics.
Okay. What else?
What
Tranexamic
else we
acid.
can use? Yes, so tranexamic acid
And the last
and
but not the least will be Nova 7,
factor
factor
combinant 7.
recombinant factor 7. Okay. And in the blood products also it's sort of pharmacological also, that you just think that it may be FFPs, cryoprecipitate, okay, and platelets.
Yes, sir.
And you will label them according to thromboelastography or Rotem finding. You can aid. Okay. So
Yes, sir.
radiologically, there is actually they place a balloon in the internal iliac vessel. Okay. And in internal iliac vessel, they place a balloon and they tamponade if needed. Okay. Then so one
Yes,
more thing you should always tell is cell salvage.
yes, sir.
So if you just want to say a few words about cell salvage, what you should tell?
So cell salvage is a process of collection, processing, and re-administration of blood loss during surgery or after surgery.
Actually, the cell salvage is like there are two suctions. One suction usually because take care of amniotic fluid. Okay. And they use special filters for it. And it is going to a closed circuit. They wash it, and it according to the machine capability, they can make it, but it will only have PRBCs. It does not have any products. Okay. So it will only replace the hemoglobin, the packed cells, not the blood products. So these things you should be knowing. And because in the exam, the scenarios may be different, they can ask you with reference to maternal collapse. Okay. That the patient is collapsed. Just a second, please. They can ask you with that reference. They can ask you these maternal hemorrhage question can come in different scenarios. Okay. Uh,
Yes, sir.
the people who are not making the mute, this is very bad. I'm requesting, I'm taking a class and nobody's even bothering to mute the mic. Okay, so please, any other exam candidate who is here right now? I would like to. Wakar, are you exam candidate? Why you don't speak anything?
जी sir, I am exam candidate.
So you should speak out, or you are only a spectator.
Sir, I have just joined and a
Oh,
little
okay.
child is with sir.
Oh, try to make him away. This is very serious business. You have
Sir,
to
sir.
ask your wife to take your kids away. This is matter of your career, and whatever benefit you will get, it will be affected on them. So please don't waste your
Right,
time. Okay.
right, sir. Right.
I will ask you the next question. You can participate in the next question. So they can ask you in a placenta previa in electively. Okay. They can ask you placenta previa in unanticipated, suddenly in emergency. Okay. They can ask you as retain product of conceptions and there will be bleeding. Okay. They can ask you with a maternal collapse. Of course, there will be other DD as well, but one of them will be bleeding because of rupture, because of abruption and things like that. So the basic protocol will be the same, but here if it is collapse, so either in the same answer of airway, breathing, circulation, you will maintain the airway, you will maintain the breathing, you will take large bore IV cannulas, and you will have differential diagnosis with reference to, so there may be any cause of differential diagnosis. Can you tell some differential diagnosis of maternal collapse? Zishan, please, can you speak out?
Amniotic fluid embolism.
Okay, what else?
Trauma, thromboembolism.
What else? I'm sorry, I just mute someone. Your voice was not very clear, whosoever was speaking. Bajiha is gone. So these are possible causes. There may be hemorrhage, embolism, cardiac causes, okay, preeclampsia, eclampsia, amniotic fluid embolism, local anesthesia toxicity, if there is any this one epidural or spinal with reference to that, okay, and failed intubation,
Anaphylaxis to any drug.
anaphylaxis, sepsis, any intracranial pathology. So you can divide it and you can tell, but you should be in your mind the same thing. Any endocrine problem, like there may be hypoglycemia, the patient is taking insulin and patient becomes hypoglycemic. So it may be a reason of collapse. Hypotension because of any reason. There may be vasovagal, there may be anaphylaxis, there may be overdosage of local anesthetics or anything like that. So you just have to, and because the management will be the same, okay? So for aortic caroral compression, you just have to do left uterine tilt, okay? You have to give fluid, you have to make sure patient is ventilating nicely, okay, that like they have written, call for help obstetrician, anesthetist, neonatologist, and because in this scenario, if the patient, you have to do the resuscitation with reference to CPR in pregnancy, what are the important things you should not forget? Yes,
To place
The CPR is
patient in
done at above.
if you are speaking, please speak loudly, okay, and please raise the hand so that I know that who is speaking. If everyone will speak, I will not be able to understand. This Mr. Anesthetist, are you exam candidate? Wajiha, can you hear?
Yes, sir. So today I am having internet connection problem, so
Yes.
I'm more on
Please,
listening.
for the exams, have some better internet connection. Okay.
Okay, sir.
So actually, what I was asking, even I forgot what I was asking. Yes, with reference to CPR in pregnancy, what important point you should be knowing? You have to compress slightly above, like slightly above in the chest. This is one thing. You have to definitely put left uterine tilt, and you have to deliver the baby within 5 minutes. Okay, so these three things uh, uh, you should be knowing in your mind. That in addition to uh, whatever the CPR protocol, this is something which you should not forget to tell. Okay. So, so with reference to these scenarios, they can ask you, like if they are asking you that there is a patient known case of placenta previa. So actually in placenta previa, whenever we say, we also should not forget placenta increta, percreta, accreta. Okay. So, so in these special things which you should be telling is the use general surgeon. Okay. they do MRI, or of course in pregnancy there will be difficulty to identify. But I think MRI can be done in pregnancy. If there is no problem in CT scan, there is a radiation problem, but there will be certain scenarios in which they can do some MRI to identify the extent. So general surgeon, vascular surgeon, okay, and urologist should be an pre-hand. And in the same, rest of the things are the same. There will be massive bleeding, and there may be need of hysterectomy, and these are things. There are RPOCs. I've told you that in RPOCs you don't have to give uterine tonics, uterine relaxants. You have to give uterine tonics. So you will even avoid inhalational agents. You will try to give even TIVA in these scenarios. So, or use relatively less MAC, because if you will give more inhalational agents, there will be more bleeding. Okay. And similarly, the abruption, or like whatever other causes, that you will be handling accordingly. Okay. So this is one important scenario they can ask. Answer is the same, believe me. You just have to identify. Resuscitation management and investigation will go side by side. Sorry, resuscitation evaluation management will go side by side, and you will be doing the same thing. You will make sure patient airway is patent, patient is breathing, large bore IV cannulas, call for help, and rest of the things. So this, because no exam will be finished without a Gyne Obs scenario. Okay. Yes, hand compression a little above. Left uterine drug overdose, concealed bleeding. Yes. Okay. So now a few words about preeclampsia. So preeclampsia, eclampsia, who will speak out? Zishan left. Any other exam candidate would like to speak out? Vajia, you want to speak out? Vakar? Yes, now your baby is away, or still you are doing the babysitting? Yes, please.
Sir, what was your question, please? Sorry, I missed
Preeclampsia.
out.
Preeclampsia. What are the anesthetic considerations in a patient with preeclampsia? Because they will ask you in that way, that you have a patient who is 34 or 35. They can make it a little premature, and this patient is having high blood pressure and or having fits, or they will only tell headache. Okay. So what will be your general approach in this patient? How will you manage? What are your aims in this patient? Actually, you have three aims. One is control of BP. Number two, control or
Seizure.
prevention of seizure. And third thing is delivery of the baby. Okay. So then they can ask you about, like this is that what is preeclampsia? Okay. What is eclampsia? What is HELP syndrome? You should be knowing the definitions, as even yesterday Zulkarnain was telling. So you should be knowing the main points about just a second, open an article about okay. So these are the uh, actually, I'm not wasting my
Sir,
time in
clinical ये anesthesia consideration तो यही will be about our choice of anesthesia, whether regional or GA, and if we opt for GA, then we will be how we will be managing the case,
okay.
like
So if
the
I
drugs
want
will
you
be.
if I want you to defend general anesthesia, what things will be supporting general anesthesia?
Um,
Okay. Airway management. Control of fits.
Okay.
Okay. So what will be the things which we are against GA? Polypharmacy, stress response. Okay. What will be the advantage or what will be the concern with reference to spinal and epidural separately? Spinal is a better choice. In with this regard that in this scenario, there may be chances of coagulopathy. So spinal is a better choice with reference to coagulopathy. Okay. But there is sudden fall in BP because less intravascular volume. So if you give spinal, there may be sudden hypotension. So you have to do appropriate preloading, preferably with colloids. Because if you give, because there is in this, especially in this scenario, there are leaky capillaries. So there may be chances of patient going to pulmonary edema. So colloids may be a better choice, or you can consider to give colloids. Epidural, the advantage is like the hemodynamic stability will be more, but this epidural hematoma and epidural abscess, this will be a problem that it can occur because the needle is very big. Here you are using 25 or 27 gauge. There you are using 16 or 18 gauge. So there are more chances of bleeding. So actually, you can defend anything. That if you say that I just need a better control of airway, you can say GA. If you want say that there will be less hemodynamic stress, and if there is no, generally, I would say that it is easier to defend GA. Okay, it is relatively better, but of course, you relatively relatively easier to defend general anesthesia. Okay. So, Hamad, finally, you have joined
Yes,
after
sir.
my repeated messages. So, would you like to speak out something?
Yes, sir.
So, how will you induce, like, if someone, if you just want to, because these are the questions sometimes they ask, how will you induce a patient with preeclampsia? So, what you should tell? You will blunt the stress response. What about intra-arterial blood pressure? There you can say that in local, you will take arterial line so that you have a better control of blood pressure. Of course, this is not a routine practice in our like setup, unfortunately, because of low resources. But in the exam, you have to tell like this that it's better to take intra-arterial blood pressure so that you can then you will say that you before proceeding, if their blood pressure is high, you can load it with magnesium sulfate. You can give some labetalol, okay, so that you are able to have a better control of blood pressure. And rest of the thing is the same propofol, rapid sequence reduction, or modified rapid sequence
Aspiration prophylaxis.
aspiration prophylaxis. Okay, because these are now I have told you before we jump into any discussion. So it's the same. You will say the same anatomical, physiological, pharmacological changes in pregnancy leading to challenging management. Okay, with reference to airway, with reference to cardiovascular system, with reference to pain and everything which we have discussed to start with. So I'm telling now, right now, we are discussing the specific things which are important in these conditions. Okay. So because the patient may be taking magnesium, so if they can ask you about some words about magnesium. So by the way, what is the role of magnesium in preeclampsia?
It is used to control convulsions and it causes hypotension and
Causes
vasodilation.
vasodilatation. Is it a better word to use hypotension? It's not a very good. You are telling the right thing, but it will be controlling of BP rather than saying, because in this scenario the blood, there is hypertension. Okay,
Yes. Magnesium acts as uh,
as what?
a calcium antagonist, and at
Very
neuromuscular
good.
junction, it decreases the acetylcholine release.
So increase effect of neuromuscular blockers.
Neuromuscular.
So how will you anticipate? You will monitor NMT, neuromuscular stimulation. Okay, or you will decrease the dose, the subsequent doses of repeat, like decreased doses of muscle relaxants. Okay, so they can ask you about what is like, how can you explain the anti-epileptic effect of magnesium? This is the answer. Decreases the excitotoxic neurotransmitter effect of glutamate and stimulation of endothelial prostacycle will reduce. You see, this is height of non-seriousness. Nobody is interested to give any respect to us. Dr. Saad, your mic is not mute. This is not good. Anyways, so this is a just a chart in which you can just see they have explained the role of each medication. Okay, so labetalol, alpha beta blocker. Okay, so what will be the problems? They have written here some bronchospasm. I don't know how significant it is. Nifedipine, calcium channel blocker. Okay, then methyl dopa. Methyl dopa is taken orally. Okay, so in our setup, usually we use labetalol or hydralazine. Okay, so with hydralazine there will be reflex tachycardia. Here with labetalol there will be less chances of reflex tachycardia. Okay, so this is the advantage. And some other medications, I don't know how much they are being used. Like they have written here ACE inhibitors, but I don't think so that they are commonly used. So I don't know why they have written here. So that's how you should identify what are the distractors. Even no source is 100% perfect, but usually in articles this is written in the best possible way. Okay. So in this topic, they can ask you what is preeclampsia, what is severe preeclampsia, what is HELP syndrome. These are definitions. So I'm not wasting my energy on it. You should be knowing what is how to identify, because this is not difficult. The difficult thing is how you construct the answer. So I'm trying to focus more on these things. So if they ask you, you should tell that in preeclampsia, the main option is to control the blood pressure, to control, prevention of fits and delivery of the baby. So you have to outweigh risk versus benefit, that how much you can delay the pregnancy, delay the delivery so that the baby maturity is achieved. So in that scenario, you will give the steroids for the lung maturation, and you will this will be of course this is not your decision. You are not a obstetrician. So but overall you will be like discussing the condition of the patient. So intensivist, because internationally ICU is a separate specialty, so try to make a habit that we will have post-op ICU. We'll discuss with the patient. We will arrange the neonatologist, and then they will decide how much, because priority is the mother. Okay, they will try to push the pregnancy as much as possible, glucolytics and blood pressure control and everything, so that they are able to have some lung maturity, but the priority is given to the mother, and if needed they will deliver the baby, and then the post-op care of the baby will be done in the neonatal ICU. So that's how you will have to answer, because they will be whatever scenario it will be, whether they will create a scenario of collapse, whether they will create a scenario of eclampsia, whether they will create a scenario of headache. Okay, so you just have to make sure that you see these are the signs which will be there in the preeclampsia. Delayed tender reflexes and neurological problem and headache and confusion and edema. Okay. And if they created fits, then it will be next stage. Okay. So I hope you understand. So one more scenario about cardiac disease in pregnancy. So actually, this is a frequently asked. They will ask mitral stenosis in pregnancy. So how you can explain this topic, Hamad? Mitral stenosis in pregnancy. Can you hear me, Hamad?
Yes, sir.
So how will you manage a patient with mitral valve disease, mitral stenosis in pregnancy?
Sir, I will start with the introduction and taking history
Listen,
about the disease,
Hamad, I'm
duration of
interrupting
disease.
you. I'm interrupting you because remember one thing, that table viva requires slightly different approach. Okay. So
Yes, sir.
usually this will
Okay.
not be a long case. This will be a table viva question, most 99% chances. So in that you use the word evaluation. Evaluation on the basis of history, examination, and relevant investigation to see the severity, that how severe is mitral stenosis, is there any failure? Now you can tell what you were telling. Okay.
Okay, sir.
Okay. So how will you assess the severity of mitral stenosis?
From the functionality of the patient during pregnancy,
Okay.
shortness of breath, easy fatigability, edema, orthopnea.
Do you know this? All these things you can tell by saying if there are any signs of failure.
Fine.
Okay.
Okay, sir.
The signs of cardiac failure will tell you all everything, because now you have to just have minimum words and clinical sign symptoms, preferably if any signs of failure. And what about investigations? How will you quantify?
Chest echo, and I will do.
Actually, you see the size of the valve, you see the transvalvular pressure gradient, you see the regurgitation if started, chamber size, chamber clot. Okay. X-ray, but you will give. You were saying X-ray. Is it a common practice to do X-ray in pregnancy? What will you
No,
get
sir.
from X-ray? Why you are saying this thing?
शील्ड के साथ सर हो सकता है, लेकिन
No, no. Why?
usually
Just a
is
second.
the
There are Hamad. There are some people who are not understanding our language. Try to speak in English. Number one. Number two. What advantage? What information you will get in chest X-ray, which you cannot get in anything else? Why you want to do chest X-ray?
there will be cardiomegaly.
So, hey, just a second. Cardiomegaly, is it important? You can get information from echo. Why you want to do
Yes,
chest
sir.
X-ray? Defend it. Now, if you have said it, defend it. You can defend still.
There will be signs of heart failure. There will be I can see
Overload.
the pleural effusion,
Overload.
blunting
Okay.
of costochromic angles.
But again, you do you know? Again, now you can say that you can have lung ultrasound.
Okay, yes, sir.
Now understand? In the exam,
Uh,
you just have to defend it. So you can say that
so,
chest X-ray, some information we can get, but because now development of our field, a good chest ultrasound can tell you everything. Whatever you are saying, everything can be identified in a good chest ultrasound and echo. So why you need to have chest X-ray? So I know that this, because this is written in the book, so you have to speak out, but you say that chest X-ray should be done only unless strongly indicated. You should try to avoid as much as possible. Okay, because
Okay, sir. Okay.
majority of information you can get from echo, and you have to tell very specifically chamber size, it says valve size, transvalvular pressure gradient, regurgitation, okay, and any clot,
Okay.
because if there is any clot, there will be chances of embolism. Okay, so you have to
Any
do
rhythm, any rhythm change.
very good, any rhythm change, especially atrial fibrillation can occur.
It
Okay,
is. Yes, sir.
anticoagulation.
Yes.
So these are
Yes.
the things which are important, so that you will and again come back from where we started. How will you stratify risk? How so you will say, I will evaluate on the basis of history, examination, and relevant investigations. Okay, and my aim will be to
Yes.
see any signs of failure,
Any sign.
because of mitral stenosis. Okay, so and then you can
Okay.
say that we will assess, and then we can have an echo, we can have an ultrasound, and we can have an ECG, and rest of the CBC and everything you can explain. But you should be knowing the reason. Whatever you will say, that how can you defend CBC in this scenario? That why you
Uh,
want to do CBC?
to check for hemoglobin to meet the oxygen demand, and
Only demand,
yes,
only demand.
dem,
Hemoglobin is for demand,
demand, and for
supply.
metabolic to prevent metabolic derangements like acidosis.
Yes, you don't need to that you need adequate amount of hemoglobin. Okay,
Yeah. Very well, sir.
and if you want to say demand, then you say myocardial oxygen demand supply ratio. If you're only
My God.
using the wrong word, it will create a bad impression. Like you did not use the word supply, you only say demand. So word demand is incomplete. Okay,
Yes, sir.
so you have
Okay.
to say to maintain the myocardial oxygen demand supply ratio, because
Yes, sir.
hemoglobin is needed to have a good oxygen, because hemoglobin is the carrier of oxygen. So if oxygen will not go, how and actually it's not define its supply, it defines the supply, not the demand. Okay,
Yes, sir. Okay.
WBC because of infection, platelets,
Yeah. Yeah,
and
yeah.
then rest of the things you can explain. Okay, so and in the same question, same way that I maintain that you have to do risk versus benefit, and you have to explain about the possible complications, and then you will do invasive arterial blood pressure monitoring, cardiac output monitoring. And it's easier, even whether it is stenotic lesion or whether it is regurgitant lesion, it is easier to defend with GA. Even if you want to speak out about epidural, you can say that we will use epidural for analgesia. Okay, and what are the common goals? Whether it is mitral stenosis, mitral regurgitation, what are the common goals? You have to maintain normoxia, normocarbia, normotension, okay,
Okay.
normovolemia,
Normal.
normothermia, okay,
Yes, sir.
avoid sympathetic stimulation,
Adequate analgesia, adequate muscle
multimodal
relaxant,
analgesia, multimodal
multi.
analgesia. And in the like other thing, you will say maintain sinus rhythm, okay,
Yes, sir. Yes,
maintain
sir.
heart rate, maintain SVR,
Yes, sir. Yes, sir.
okay. So
Sir,
that's
इसमें
how,
जो
yes.
in regurgitation, regurgitant lesions and stenotic lesions, there is some difference about the heart rate and the
Remember,
systemic
how will you
valvular
explain?
resistance.
Because majority people say, I will cause bradycardia, I will cause
Yes,
increase SVR, then they will fail you, because this is not an answer. You say, yes, say that, because in the books it is written stenosis, slow and tight.
Yes, sir.
So, but it doesn't mean that you will say, I will cause bradycardia. If there is bradycardia, how the cardiac output will be maintained? If there is increase in SVR, heart is already hardly pumping. So, if you will increase SVR, how will? So, answer is not this. Answer is that you will maintain the heart rate in the low range, lower normal, and you will not
Sir,
allow to have tachycardia. Okay.
okay.
And similarly, you will
This
maintain the
fixed
SVR.
heart rate. When the author says we have to slow and make the patient tight, they say it is because it is the fixed cardiac output in stenotic regions. That's why we have to make the patient heart rate slow and systemic valvular resistance increase.
No, no, that's what I'm telling you, and you are repeating the same thing. Try to understand what I'm saying. If
Yes,
you
sir.
if you think, if you, for example, okay, consider mitral stenosis, what will be the effect of
Yes,
increased
sir.
SVR? The heart is not contracting nicely. What is the basic
Afterload,
pathology? So if afterload
afterload
is
will
in,
increase,
so is it good?
but cardiac output is fixed and systemic vascular resistance is increased, then heart will perform better
No.
if there will
Hamad,
be if systemic.
Hamad,
Yes, sir.
Hamad, just try to
Yes, sir.
listen to what I'm saying, and then you will understand what I'm trying to say. I'm not saying that you
Okay.
will not. So better answer is that you will maintain SVR. Listen what I'm saying,
Okay, sir.
and don't let it fall.
Yes, sir. Yes, sir. Yes, sir. Very well said. Very well said, sir.
Okay. Similarly, you will maintain heart rate, and you will
Yes, sir.
not let it tachycardia. This is the answer.
Very well said.
Okay.
Excellently explained, sir. Very well said.
Because you don't need, if you increase the afterload, again heart will be collapsed. They have to maintain the SVR so that cardiac output is maintained. If SVR is decreased, there is decreased venous return. There is nothing, because hardly there is, the door between the left atrium and left ventricle is closed, so there is hardly blood going, very slowly. So if the venous return is decreased, the volume coming to left atrium is decreased. So the volume going to left ventricle will be decreased. So there will be, the heart will not be able to maintain the cardiac output. This is the theory. Similarly, is SVR is decreased, there will be no pressure to pull to maintain the blood pressure and maintain the circulation. So that's the concept. So whenever we read about it, unfortunately, we read it wrongly. So same is true for regurgitation. What's the problem if there is decreased heart rate in regurgitation?
There will be greater backflow of
Very good.
regurgitant fraction of the.
Regurgitant fraction will increase. Okay. So I hope you understand. So you will say in regurgitant, you will try to maintain the heart rate, and you don't let it bradycardia, because bradycardia will cause to knee increase. So you will try to maintain it, try towards high normal and high, like you will maintain the systemic vascular resistance, and you will not let it increase, because now again, if the forward pressure is more, if the afterload is increased, heart need more pressure to push the blood. So already
Yes.
the back doors are open. So if heart will
Yes.
push more to forwardly, more blood will go back. So that's the concept of any valvular heart disease. And rest of the thing, prevention of bacterial endocarditis. Okay.
Yes, sir.
And rest of the things are the same. So you will take arterial blood pressure monitoring, cardiac output monitoring, maintain these things. These are my best friends. Okay. Maintain oxygen, maintain CO2, normotension, normovolemia, normothermia, sympathetic stimulation, multimodal analgesia. Try to maintain the heart rate, maintain the sinus rhythm, systemic vascular resistance. That's it. So if you understand this thing, you will be able to answer. If you don't understand this thing, you will not be able to answer. So the same is true for peripartum cardiomyopathy. Because in peripartum cardiomyopathy, what is the extra thing? That is, it is the diagnosis of exclusion. There should not be any cardiac disease before, and there is new origin of heart failure after 20 weeks of pregnancy. Okay. So there are some certain risk factors, you can read about it. The failure signs are the
20,
same.
sir, 20 weeks of pregnancy?
Yes.
Okay. I have read about 28 after 28 weeks of pregnancy,
Uh,
cardiomyopathy in pregnancy.
just a second.
Sir, in last trimester and on till 5 months after pregnancy.
Yeah, yes,
So,
yes.
so last trimester starts after how many weeks?
Sir, in the weeks of uh,
So
till
you
5
see,
months.
there are total 40 weeks. Sometimes wrong words come out of your tongue. So actually, this is just a second. Let me, because same is true for the hypertension, pregnancy induced hypertension. This is the same thing. Just a second. Let's reconfirm.
Pregnancy-induced hypertension, that is 18th week of pregnancy, I think.
Sir, I think it's written in the last article which we were viewing.
Anyways, if I tell something wrong, please correct it, because numbers I am giving you a concept. Okay, so these things I
Okay,
can,
sir.
because I'm not studying, so I can just slip out of my mind. In my opinion, it is the last week, last trimester. So it should be after 20 weeks, if I'm not wrong. Anyways,
Okay.
reconfirm it so that we don't waste our time. We are already short of time.
Okay.
So remember one thing, the same failure things can occur. Same atrial fibrillation can occur. The same or orthopnea, PND can occur. So there is no difference. Okay.
Okay.
So you see, I was correct. I was correct. Heart failure towards end of pregnancy or up to 5 months after postpartum. So last trimester. Okay.
Last
So
trimester. Okay, sir.
last trimester, third trimester will start after how many weeks? So you see, I'm just confused. I think you're right. It should be 24, not 20.
25.
20,
After
20.
24, I think.
Yes, after 24, you are right. Okay. So I just said by mistake 20. So it is after 24. Okay. So it's a
Okay, sir.
diagnosis of exclusion. So there is heart failure towards the end of the pregnancy and even after delivery. And there is another no identifiable cause of cardiac failure. Okay. An absence of cardiac symptom prior to late pregnancy. And there is severe left ventricular dysfunction. So that is the thing. And then the rest of the things are the same. Here again, because the heart is very weak, they will give you a scenario that there is a shortness of breath, and when they did the echo, the ejection fraction is 20%. So how will you manage? So again, will be a high risk, same invasive monitoring, same things, and then your target will be to maintain everything. Okay, so you will use
Okay,
for
sir.
induction, you will use etomidate because it is least cardiac depressant, and you will just try to give accurate fluid. You have to maintain the fluid volume. You have to, and then there may be need of pacing intraoperatively. There may be it will be a high risk case. So you can in this scenario maybe you need pacing if there is any bradyarrhythmias, and you might need to have support from the inotropes. Okay, and
Okay.
for the management they give AC inhibitors because AC inhibitors are teratogenic. But here you have to just do risk versus benefit. They will be doing some vasodilators to maintain the cardiac output, and digoxin because there may be as a inotropic, positive inotropic. So because these are the things which are for medical management. For the conduct of anesthesia, it's very easy. If you go in details, again the same answer you can do for all cardiac patients, whether it is peripartum cardiomyopathy or any other cardiomyopathy. The answer is the same. You just have to give GA, general anesthesia, blunting of stress response, invasive monitoring, cardiac output monitoring, maintain all the best friends, okay? Judicious fluid management, goal-directed
Okay.
fluid therapy. These words will cover all possible scenarios. Okay?
Excellent, sir. Excellent.
So same thing, yes.
Sir,
And here, yes.
how will sir please how AC inhibitors will work in cardiomyopathy?
It's just to as a vasodilators. Okay, because
Okay.
like it is to decrease the load on the heart. Okay, like heart
Okay.
failure, in the heart
Okay.
failure, two things. One is to increase the contractility, and one is to reduce the
Yes,
pressure
sir.
on the forward flow. So vasodilators, any
Okay.
vasodilators which we are being using is to reduce the pressure on the heart. Okay, so that's what they have
Okay.
written here.
Okay.
So again, you see, these are medical managements. So in the exam, you should be thinking, and then you see, you can remember these things because they can ask you as well, that maybe need of intra-aortic balloon, left ventricular assist device, and ECMO. Okay, and even heart
Okay.
transplantation. In the like if they are saying, oh, what more. So as I told you, pacemakers, cardiac resynchronization therapy. So because there may be a lot of problems which these patient will be thinking, and even as written here, preconceptual counseling, they try to avoid pregnancy, even if it is early phase and it's threat to the life. According to the legal and moral issues, they can abort the pregnancy. Okay, but if the pregnancy is progressed, if there is chances, like for example, if someone has history of this one, they will try not to have pregnancy, because of course the first time when it occurs, now they cannot do anything because it is already the pregnancy is progressed. So this counseling is for further pregnancy. Okay, because if it
How,
occurs.
how how much time we will say it is progress pregnancy after 12 weeks, after 16 weeks,
No,
after
actually,
20 weeks?
no, according to this is actually legal and moral issues a lot, and according to the safety of the baby. Usually, if it is less than, I think, 12 weeks, it's I think I don't remember this thing. So you please reconfirm about it.
Excuse me, sir. Sir, it
Yes,
would be fair to say that regarding cardiac disease in pregnancy, if we know the management of aortic stenosis, then we can add the physiological changes of pregnancy and
exactly.
give our
The
answer.
same. Actually, remember one thing. Now, like it's been almost more than 1 hour now since we are discussing. The common things are the same. That's why I started from the common things. If you don't forget to tell the common things, believe me, it's very easy to answer. Okay, like the basic need to avoid. You have to maintain the fluid dynamics. You have to maintain because in this there is slightly overloaded situation. So you will avoid anything which can further decompensate. Okay. So these are the things which the same principles will apply whatever question they are asking you. Okay. So I think if anything missed, because I have discussed all these topics separately also before. So in the YouTube channel, you will find
Yes,
in the
sir.
Gyne Obs. So now actually I'm feeling low in energy. Okay, a lot of so if anything miss, we can discuss. But I will try to cover one unit every day. So try to revise. Okay. And if you have any
Yes.
questions about Gyne Ops, you can just drop a message and we can discuss. I actually, uh, just a second, you see, I have discussed a number of time same things. So you can just listen to it. Like I discussed diabetic decay in pregnancy, peripartum cardiomyopathy in detail, I have discussed. So labor analgesia I missed. I will try to cover in with the pain. Okay, I will try to cover there because that's also very important. So you can just have a listen to it, and a lot of your concepts will be clear. So tomorrow we will try to have similar class on pediatrics. Okay. So
Okay, sir.
thank you.
Okay.
Thank you very much. And
Thank you.
special thanks to Hamad, because Hamad I was calling. So I hope you are benefited. Okay. And also Wajiha.
सर वेरी सर आपका बहुत शुक्रिया, वेरी वेल एक्सप्लेन। ये
Okay.
फर्स्ट टाइम जो है ना मुझे ये मतलब इस चीज का कॉन्सेप्ट सही हुआ है कि माइट्रल स्टेनोसिस और रिगर्जिटेशन में हमने किस तरह हार्ट को
बोलना
लेके
है.
चलना है। वेरी मास्टरली एक्सप्लेन, अल्हम्दुलिल्लाह।
Okay. Okay. Thanks a lot, all of you, for honoring me. Inshallah, we will meet again. Okay. So, and a special thanks to Fahad Shinwari, because I really want to thanks, because Fahad has very good concept. I don't know when, we all should pray that Fahad buy a mic so that he can speak, because he's all everything he's writing, and he said that my mic is not working. So I wish are you a human being, or are you a robot? Because I'm afraid you are artificial intelligence. You are not a human being. So I'm really afraid. Fahad, okay? Hope to listen to your sound, your voice. Okay, my dear. Thank you very much. And special thanks to Vakar. And I think Vakar, we should contact his family so that they relieve him for the Viva. Okay, Vakar?
Sir, thank
Okay.
you, sir. Thank you.
Bye bye.
Thank you, sir. बहुत बहुत शुक्रिया सर।
Okay, thank you.